Hello friends, welcome back. Today we'll learn about hyperthyroidism. Let's start with a clinical scenario. A 26-year-old woman who is 30 weeks pregnant presents with palpitation and neck swelling. She has been unable to gain any weight thus far and has been feeling anxious. Pulse is 115 per minute. Fetal heart tones are present at 135 per minute. Physical examination reveals a diffusely enlarged non-tender thyroid and a symmetric fine tremor. A lower extremity examination reveals the findings shown. Which of the following is the underlying mechanism of this woman's most likely condition? To know the answer, let's start today's lecture. Hyperthyroidism is a condition that causes excess thyroid hormone, and therefore it is sometimes referred to as thyrotoxicosis. And the thyroid hormone production is under the control of hypothalamus and the pituitary. In my previous video about hypothyroidism, I have explained you about the physiology and the normal function of the thyroid gland. So please do check it out for revision. Let us start with the symptoms of hyperthyroidism. The first, the individuals with hyperthyroidism tend to be hyperactive and they present with tremor in the extremities. It can also cause anxiety, irritability and mood swings as well as difficulty sleeping. Hypothyroidism can also cause an increased appetite. It is with an unexplained weight loss. Though the appetite or the food intake has been increased, then also the patient or the individual suffers from weight loss. And there is also more frequent bowel movements. This is important that the patient suffering from hyperthyroidism suffers from diarrhea and unexplained weight loss. On a physical examination, the skin is warm. In the case of hypothyroidism, we have seen that the patient usually feel cold. But in the case of hyperthyroidism, the patient feels too much of heat, and the skin is also warm and moist, and their hair is fine and brittle. Classically, individuals have lid retraction, which makes a person look wide-eyed. What is eyelid retraction? It is actually a condition where there is upward displacement of the upper eyelid or downward displacement of the lower eyelid, thereby exposing the sclera. Sclera is what is the white part of the eye. This makes the person look wide-eyed. Now, some other symptoms of hyperthyroidism include pretibial myxedema, which is a waxy, discolored induration of the skin on the anterior aspect of the lower legs, with a bumpy feel like an orange peel. Pretibial myxedema is seen usually in the case of Graves' disease only, not in the case of every hyperthyroid disease, but it is peculiar for Graves' disease mostly. And pretibial myxedema is what the picture of the clinical scenario in the starting of the lecture presented to you. जो पिक्चर हमने लेक्चर स्टार्ट करने से पहले क्लिनिकल सिनेरियो में देखा था वो एक्चुअली इंडिकेट कर रही थी प्रीटिबियल मिक्सेडेमा को. Now, due to hyperthyroidism, there may also be muscle weakness, especially in the thighs and upper arms, as well as there will be exaggerated deep tendon reflexes. And in the case of cardiovascular system, we can see tachycardia as well as atrial fibrillation or systolic hypertension. Females can suffer from menstrual irregularities and males can have gynecomastia, which is the swelling of the breast tissue. And finally, due to hyperthyroidism, there can be high blood sugar levels, excessive urination, excessive thirst, and delirium. Hyperthyroidism often presents with a single symptom evolving over weeks to months. Causes of hyperthyroidism. There is 8 main causes of hyperthyroidism. The first being the Graves' disease. The second is pituitary adenoma. The third is the high levels of human chorionic gonadotropin or HCG. The fourth is the toxic multinodular goiter. Fifth is Hashimoto's thyroiditis. Sixth is subacute thyroiditis, also called de Quervain's thyroiditis. Seventh is struma ovary. And the eighth one is JOD-BASEDOW phenomenon. In this first three leads to excess of TSH receptor stimulation, leading to increased secretion of T3 or T4, thus causing hyperthyroidism. Whereas in the previous lecture of hypothyroidism, we have studied about Hashimoto's thyroiditis and the subacute thyroiditis, where they both of them cause transient hyperthyroidism. That is when, due to hyperplasia of the gland, they first causes increased release of T3 and T4, but then due to autoimmune damage or due to damage of the thyroid cells, then it causes hypothyroidism. For more information, please do watch the video related to hypothyroidism. Graves' disease. Graves' disease is an autoimmune condition where the thyroid stimulating immunoglobulins or TSIs bind to the TSH receptors and stimulate excess hormone production. So, Graves' disease is also an autoimmune disease like Hashimoto's thyroiditis, but unlike Hashimoto's thyroiditis, जहाँ पे ऑटो एंटीबॉडीज जो थी वो थायराइड ग्लैंड को डिस्ट्रॉय कर रही थी, जो ग्रेव्स डिसीज में ऑटो एंटीबॉडीज फॉर्म होती है वो थायराइड ग्लैंड को डैमेज नहीं करती है, बट वो एक्चुअली उनके TSH रिसेप्टर से बाइंड करके उनको स्टिमुलेट करती है टू रिलीज एक्सेस ऑफ T4 और T3 एंड thus it leads to hyperthyroidism. समटाइम्स जो ये एक्सेस स्टिमुलेशन होता है वो थायराइड ग्लैंड को स्वेलअप कर देता है और उसमें गोइटर हमें देखने को मिलता है. बट द मोस्ट इम्पॉर्टेंट कैरेक्टरिस्टिक फाइंडिंग जो ग्रेव्स डिसीज की होती है वो होती है एक्सऑफ्थैल्मोस. This is the main point which you have to remember, that the most characteristic finding in Graves' disease is exophthalmos, which is where the eyes bulge out of their sockets. In this picture, we can see exophthalmos where the eyes are bulging out of their sockets. It is very much important. I am repeating it again that exophthalmos is only specific for Graves' disease. It can never be found in any other kind of hyperthyroidism. Now, how does it happen? Actually, the autoimmune reaction that take place in Graves' disease leads to activation of T cells. That further leads to a lymphocytic infiltration of retroorbital space that increases cytokines, and then the cytokines increases the fibroblast secretion. और फिर फाइब्रोब्लास्ट जो होता है वो ग्लाइकोजामाइनोग्लाइकेंस को सिक्रीट करना शुरू कर देता है, जिसकी वजह से जो ऑस्मोटिक होता है प्रेशर वो इंक्रीज हो जाता है और फिर मसल swell हो जाता है due to water retention, and then we come to see muscle inflammation, and also जो adipocyte count हो जाती है वो भी increase हो जाती है, and this all in total results in exophthalmos. Graves' disease is the most common cause of hyperthyroidism. The thyroid stimulating immunoglobulin are the IgG antibodies or immunoglobulin G antibodies, so they can therefore cross the placental barrier, and then because of this they cause transient neonatal hyperthyroidism. Graves' disease belong to type 2 hypersensitivity reaction, because as we all know that in type 2 hypersensitivity the antibodies are directed against cellular or extracellular matrix antigens, as we see here in the case of Graves' disease. Now, since the thyroid stimulating immunoglobulins lead to the activation of fibroblast, so if it leads to activation of dermal fibroblast, we see the condition as pretibial myxedema. Whereas if it causes the activation of orbital fibroblast, we see the condition as Graves' orbitopathy, also known as exophthalmos. Both of these are important to diagnose Graves' disease. Graves' disease often presents during stress, for example in the cases of pregnancy. And as Hashimoto's thyroiditis, it is also associated with some human leukocyte antigen. Here specifically it is associated with HLA-DR3 and HLA-B8. Whereas in Hashimoto's thyroiditis, it was associated with HLA-DR3 and HLA-DR5. Histology of Graves' disease. Now let us see how the follicular cells of the thyroid gland appears in the case of Graves' disease. So here we can see that the follicular cells have become tall. They are no more cuboidal as in the case of a normal thyroid gland. Also we see there is crowded follicular epithelial cells. There are so many. For example, if this is the thyroid follicle, this is the thyroid follicles over here, this is the thyroid follicle, we can see how many follicular epithelial cells have been appeared with the colloid been destroyed. Now how to diagnose Graves' disease? So in the blood test we'll see high thyroid hormone levels, that is high T4 and T3, whereas low TSH, this is mainly because of negative feedback. Elevated thyroid stimulating immunoglobulin antibodies levels confirms Graves' disease. So the confirmation through blood test that this is the particularly Graves' disease is made when we see the elevated TSI antibodies. Also there will be a large thyroid but without any palpable nodules. And finally, the diagnosis, if the diagnosis of Graves is not clear, then if we feel that there is some another cause of hyperthyroidism, so the next step for diagnosis is to take a radioactive iodine uptake scan or RAIU scan. In an RAIU scan, a person is given either a capsule or a liquid that contains the radioactive isotope or iodine, typically iodine 123. Now the functional thyroid tissues, they love this iodine and they gobbles or takes them up to make the thyroid hormones. So to see how much thyroid tissue is actively making hormones, we perform a scintigraphy scan. What is a scintigraphy scan? It is a procedure that produces pictures or scans of structures inside the body. The principle of this procedure is very simple. It says that the more active the thyroid is, the more iodine it will take, and as a result, the more radiation it emits. Now, a gamma camera is used to pick up the emitted radioactive signal and the computer translates this into pictures with a white background, where the dark areas represent radiation emitted by the functional thyroid tissue. A set of the scans is obtained 4 to 6 hours later and then another set is obtained 24 hours later. A normal thyroid gland looks like two grey wings. With Graves' disease, there is a diffuse increase in the uptake of both lobes of the thyroid, so the thyroid appears darker and larger. So this slide demonstrates the radioactive iodine uptake scan images. This picture demonstrates a normal thyroid gland with white background and the dark area representing the functional thyroid tissues. It looks like two grey wings. Whereas in this picture, we see that the thyroid appears darker and larger, thus indicating Graves' disease. Treatment for Graves' disease. If Graves' disease is confirmed, then the treatment should be initiated with antithyroid medication, the thionamides like methimazole and propylthiouracil or PTU. Thionamides inhibit the enzyme thyroid peroxidase inside the thyroid cells and thus stops thyroid hormone synthesis. For both methimazole and PTU, a high initial dose is used, and then once euthyroid status is achieved, that is when the free T3 and T4 levels go back to normal, then a lower daily maintenance dose is used. If individuals have really large goiters compressing nearby structures like trachea or recurrent laryngeal nerve, then the surgical removal of the thyroid gland is important, which is called thyroidectomy. The compression of the trachea causes trouble in breathing, whereas the compression of the recurrent laryngeal nerve causes hoarseness, and therefore the surgical removal becomes important. Pituitary adenoma, it is one of the another cause of excessive TSH receptor stimulation, causing increased T3 and T4 release. A TSH secreting pituitary adenoma is when a tumor forms in the pituitary and secretes TSH regardless of any negative feedback signals. So in this situation, we find that there are high free T3 and T4 levels with high TSH levels. It is the only exception to the high thyroid hormones, low TSH rule of hyperthyroidism. So it is the only hyperthyroidism where we see that there is increased T3 and T4 with increased TSH levels. So this is important for you to remember. This actually helps us to differentiate between the hyperthyroidism caused due to pituitary adenoma from the other causes of the hyperthyroidism. In this case, for diagnosis, to identify the adenoma, we usually do CT or MRI scan of the head, and for the treatment, then we surgically remove the adenoma through transsphenoidal adenomectomy. In this picture, we can see the procedure of transsphenoidal adenomectomy. This is a type of surgery that can be used to remove the adenoma of the pituitary gland through nose. High levels of human chorionic gonadotropin also results in increased stimulation of TSH receptors. Now, how this happens is HCG is structurally similar to TSH. It can bind to the TSH receptors and then it stimulates it to release more T3 and T4, causing hyperthyroidism. HCG levels normally rise during the first trimester of pregnancy, and this sometimes results in a transient state of hyperthyroidism that resolves on its own. But other causes of excess HCG are HCG secreting germ cell tumors of the testicles or ovaries, or a hydatidiform mole. Hydatidiform mole is an abnormal kind of pregnancy where the placenta develops with very little fetal tissue and secretes too much HCG, but the fetus isn't viable. That is, the fetus isn't alive. Diagnosing germ cell tumors can be done via CT scan or MRI or in ultrasonography of the pelvis in the situations of females, or in testicles in the situation of males. Hydatidiform mole can be seen in pregnant females who have HCG levels much higher than normal for the first trimester of pregnancy. It presents with hyperthyroidism, vaginal bleeding, and hyperemesis, which is extreme nausea and vomiting. Often on ultrasound, we can see a characteristic aspect of the hydatidiform mole where the intrauterine mass with cyst looks like a bunch of grapes. Treatment of germ cell tumors and hydatidiform mole, however, is the same and involves removing either the tumor or the hydatidiform mole. Now let us see how abnormal T4 or T3 secretion can lead to hyperthyroidism. It basically occurs in two conditions. First, in toxic adenoma, and the other one in toxic multinodular goiter. In toxic adenoma, there is formation of one hot nodule. What does it mean when we say hot nodule? It is a thyroid nodule where some amount of thyroid tissues starts secreting abnormally high levels of T3 or T4. Whereas in toxic multinodular goiter, there is formation of more than one hot nodules. These nodules can be felt on palpation or can be seen on a radioactive iodine uptake scan, where the areas with nodules appear darker than the rest of the thyroid. In this situation, some spots in the thyroid gland look darker than other parts. The radioactive iodine uptake scan alone can establish the diagnosis for either the toxic adenoma, where we'll see a single dark spot, or toxic multinodular goiter, where we will see multiple dark spots. In this slide, we see radioactive iodine uptake images for different types of causes of hyperthyroidism. In the first picture, we see the hyperthyroidism caused due to Graves' disease. In this, the whole thyroid gland appears darker as compared to the normal thyroid gland. In this picture, we see thyroiditis, which can either be Hashimoto's or subacute thyroiditis. In this, there is near absent radioiodine uptake. Thus, the thyroid gland appears to be pale, less darker, or we can say least darker, as both the conditions of thyroiditis result in destruction of the thyroid tissues. Here we can see a cold nodule thyroid, where this is a thyroid nodule that does not produce thyroid hormone. This is certain tissue inside the normal thyroid gland which are destructed or destroyed, and due to which they are unable to produce the hormone. Whereas we can here see the hot nodule. These are hyperactive thyroid tissues which are secreting abnormally increased levels of the thyroid hormones. And this is actually the case of toxic adenoma. Lastly, we see the case of toxic multinodular goiter, where there is formation of multiple nodules which are hyperactive and secreting abnormally increased levels of T3 or T4. Now let us read some extra thyroid sources of thyroid hormones that can lead to hyperthyroidism. For example, in the cases of hypothyroid individuals, if they are treated with too much of thyroid hormone, it can lead to hyperthyroidism. Or when a person self-administers thyroid hormone even without being hypothyroid, then people might do this when they want to lose weight. In fact, some supplements for weight loss contain thyroid hormones. So the basic treatment for these kinds of people will be adjusting the doses, or to stop taking the thyroid hormone. Another important extrathyroid source of thyroid hormone is struma ovary. It is a teratoma which is made up of thyroid tissue that grows on the ovary and secretes thyroid hormone. This is very much important. Please do remember this. And this can be diagnosed with an ultrasound of the ovaries, a CT or an MRI scan of the pelvis. An radioactive iodine uptake scan of the pelvic region will demonstrate higher iodine uptake in the mass than in the thyroid gland. Treatment is the surgical removal of the mass, which should be examined histologically to confirm the diagnosis. Now let us study about thyroid storm. It is uncommon but a serious complication that occurs when hyperthyroidism is incompletely treated or untreated, and then significantly worsens in the setting of acute stress such as infection, trauma or surgery. It presents with agitation, delirium, fever, diarrhea, coma and tachyarrhythmia, which is the cause of death in the cases of thyroid storm. Now we treat thyroid storm with 4 P's. The first is the propranolol, which is a beta blocker. The second is the propylthiouracil, which is a thionamide that suppress or that inhibit the enzyme thyroid peroxidase. The third one is the prednisolone, which is a corticosteroid which results in decrease in inflammation. And fourth one is the potassium iodide or the Lugol's iodine solution. Now, why is this potassium iodide added with the treatment? Because as we have seen the Wolff-Chaikoff effect, where the iodide load actually decreases the T4 synthesis. This we studied in the previous slide when we were talking about hypothyroidism. hyperthyroidism. Now let us study JOD-BASEDOW phenomenon. This is an iodine-induced hyperthyroidism. It is opposite to Wolff-Chaikoff effect, where the iodine overload suppresses the thyroid hormone release. In the JOD-BASEDOW phenomenon, the iodine induction causes the increase in the thyroid hormone release. This phenomenon occurs when a patient with iodine deficiency or partially autonomous thyroid tissue, that is partially active thyroid tissue like active nodule, is made iodine replete, means or if they are provided with more iodine. This can happen after iodine IV, where intravenously iodine is given to such individuals, or in the cases of amiodarone use, because amiodarone itself contains 2 iodine atoms. So back to our clinical scenario. Now, as I told you earlier that this picture demonstrates pre-tibial myxedema, which is the characteristic finding of dash. ये मुझे आप लोग बताएंगे. So please do comment your answer in the comment section below. Also, please type the answer to this clinical scenario in the comment section. The questions related to both hyper and hypothyroidism will cover in our upcoming video. For now, thanks for watching. Please do like, share and subscribe. Also, do comment your answers and press the bell icon for more updates.